All right, well, hey everyone. New face here in this box. Well, not new face, but new role. I am Valeria Levy, and I'm the new interim executive director for North Carolina AIDS Action Network, and would like to welcome everyone to our first in a series of potentially 4 of the MPox files. We have a action-packed day set up for you. You can't say MPox files without saying action-packed, because it takes me back to the X files. So, you know, that was full. I was only a mere little small child, and I just have a really good memory. I may have been 3 when the X files was out. At least that's what I'm going with. But for those of you that are new to North Carolina AIDS Action Network and maybe received this invite from a friend or saw it on a social media post, just a quick blurb. We are a statewide organization here in North Carolina. We're focused on HIV, viral hepatitis, and really broader health equity advocacy and policy. And that makes us extremely lucky to be able to work with great people like the people you see on our screen. So I am going to introduce both of these fantastic people to you right now. And again, thank you all for joining us. I was really hoping that that would come back through, Greg, but I'm going to go with the one that I have. Which just went away from my screen. That's just, you know, how it would go. Well, let me start with this one. So I am not going to butcher your name, Greg, so I'm going to try my best to put my flair with it and say Gregorio, but I know I didn't roll my R correctly, and I lovingly call you Greg. So Greg Millet is a vice president at amfAR, the Foundation for AIDS Research, and director of amfAR's Public Policy Office. Former CDC senior scientist in the Division of HIV/AIDS Prevention, DHAP, and has published in top medical, public health, and policy journals. Mr. Millet also served as senior policy advisor in the White House Office of National AIDS Policy, where he helped to author President Obama's original national HIV/AIDS strategy and worked to support the strategy's implementation across the federal government. In 2020, Mr. Millet was the opening plenary speaker for the International AIDS Conference. He also published the first national research studies assessing the impact of COVID among Black and Latino Americans, which received wide national and international media coverage. Mr. Millet serves as a member of the HIV Prevention Trials Network, PEPFAR Scientific Advisory Committee, the COVID-19 Prevention Network, CDC HRSA Advisory Board, and now Monkeypox. Here we are again with another pandemic, potentially. I tell you, it's just, it goes on and goes on, and I'm glad for us to have Greg here with us. Also, once I pull up Lee's, Greg, do you want to wave your hand, say hello?
Hi, everybody.
He's like, that's it. That's my whole thing. Lee, I am going to pull yours up. I swear I have it.
I'm glad to do a quick bio for myself, if that's
I don't want you to do a quick bio for yourself. Here it is. I got it. Lee Stevens, who is the Senior Advisor, Office of Intergovernmental and External Affairs for the US Department of Health and Human Services. In his role, he's led the policy team for the Office of Engagement with state and local elected officials, which focuses on issues like Medicaid, temporary assistance for needy families, and other HHS programs. But lately, as we all know, his work has strongly been focused on COVID and MPox. And Lee happens to be a North Carolina native and has lived in DC since 1993, working for former US Congressman Charlie Rose, North Carolina Governor Jim Hunt in his DC office, and the US Department of Health and Human Services. Welcome, Lee.
Thank you. Glad to be here.
Thank you for being here. So everyone, today what we're going to do is start with a background. Greg will start that conversation and kind of bring us up to speed on what we're seeing right now in the US on monkeypox. And I believe some are now starting to call it MPox. So we'll start with that and give everyone an opportunity to hear that part of the presentation. We will then move on to Lee's presentation. And after that, we'll have time for question and answer. So thank you all, and we'll go ahead and get started. Greg, you're next.
Great. Thank you, Valeria. And I want to thank NCAN for the opportunity to speak this morning. It's really a pleasure to be here with Lee Stevens to talk about what's taking place with monkeypox, both here in the US as well as globally. And quite selfishly, you know, I got my MPH from UNC Chapel Hill. So I really miss and love North Carolina. It has a special place in my heart. And it's great to see so many people who are online, who are new, as well as old friends. So today I'm just going to give a quick presentation about some of the knowns and unknowns of the global and US monkeypox outbreak. Let's see if I can move this together. Here we go. So in terms of what's taking place right now, we're seeing that there is a new multi-country outbreak of monkeypox. And the way that it's affecting the world is, you know, monkeypox is essentially an orthopox virus. It's related to smallpox. It's related to camelpox as well as cowpox. It's not chickenpox, and a lot of people keep thinking that it's part of the same family, but it actually isn't. And monkeypox is a bit of a misnomer because the disease is passed from rodents to humans. And in terms of what we're seeing in the world, we've seen the first cases of monkeypox in this new outbreak being detected in Europe, and then moving a couple of months later to detection here in the United States. And when we take a look at the trajectory of the monkeypox outbreak across the world, there are about 49,000 cases that have been diagnosed thus far. About 18,000 of those cases are in the European region, another 18,000 in the United States. Europe was the first to really see this huge increase in monkeypox cases. And you can see that here between Spain as well as the United Kingdom. But then we see this decrease in the number of cases that are taking place in Europe. We're actually seeing a 21% decrease in cases across Europe. In the US, we're still seeing you know, cases sort of plateauing here. And we're seeing a bit of a decrease in specific parts of the US. But unfortunately, just in the last week alone, you know, the US represented 60% of monkeypox diagnoses just in the past week. So we really are the edge of what's taking place in terms of this outbreak globally, just as we were with COVID-19. And when we take a look at the monkeypox diagnoses, as I mentioned beforehand, they're decreasing across the globe and in parts of the US, 21% across the globe, as well as in specific US cities, New York City and San Francisco, where we're seeing a decrease in cases, but we have to be really careful about that decrease in cases. I think a lot of us who are epidemiologists are cautious in terms of what that means. And part of the reason is because, you know, diagnoses are not the same as actual cases. I know of a couple of people who had monkeypox. It was very clear that they had monkeypox, but they were not diagnosed. So we do think that the number of cases still exceed the diagnoses that we're seeing. And then the second reason that we have to be careful in terms of the decrease is that we don't know if there's going to be a bimodal distribution. And what I mean by that is that we don't know if there's going to be a decrease in cases for now, but that's basically because monkeypox has entered the coastal cities first, and now that there's going to be an increase in cases in more of the interior of the US. And that's what happened with HIV, that's what happened with COVID-19, where we saw decreases on the coast, and then we saw these increases in the middle of the country. So I think we're in a bit of wait and see mode to see if this decrease is actually real. Now, one thing that's also very clear about the monkeypox outbreak, particularly here in the US, is that we started vaccinations too late to stem the outbreak. And one thing that my colleagues and I did here at amfAR is we wanted to project the number of cases that we would expect to see from monkeypox from early July. So we did a quick analysis to project what that might look like. And in July, when we did our presentation, we looked and we found that there were only 800 cases that were diagnosed in the US at the time. But then we said that within a month's time that there would be 11,000 cases that would be diagnosed. And what actually came to pass was true. We were only off by a week where there were 11,000 cases that were diagnosed by August 12th. Now, the reason that we chose that date first of August 4th is because monkeypox vaccines began in New York City as early as June 23rd. And as many of you know, to be fully vaccinated for monkeypox takes 6 weeks. So it takes a month after your first dose to get your second dose, and then 2 weeks after your second dose, you're considered fully vaccinated. So we wanted to see what the number of cases would be from the very beginning of these community vaccination programs that were the first in the US that took place in New York City. And it's huge. You can see that it went from 173 cases from the time that we started these community vaccinations across the US to 12,000 cases within a 6-week period. The other bad news that we're seeing as well is that not enough people are returning for their second dose of the vaccine. That's something that is crucial. According to CDC Director Rochelle Walensky, there's been about 200 doses of the vaccine across 19 jurisdictions by August 23rd. 97% of those, unfortunately, are first doses, and very few people are coming back for their second dose. If people don't come back for their second dose, it's likely that we might see some viral mutations. It's likely that we might see an increase in monkeypox cases. So it's really crucial that we get people to come back for their second dose of the vaccine. The other thing that is notable about this outbreak is that, it's not the first outbreak that we've had in the United States of monkeypox. There's been several outbreaks or several cases of monkeypox in the US before. In 2003, there was actually an outbreak with 47 cases across 6 states in the US, all of it stemming from people who had pet prairie dogs. And these prairie dogs were infected with some other mammals that were coming in from Ghana. And then the prairie dogs infected their human owners. There's also been very recent cases of monkeypox as well here in the United States, and all of them travel associated from Nigeria. So in November 2021, there was a US resident who came back from Nigeria who was diagnosed with monkeypox. In July of 2021, earlier that year, there was a Nigerian national who came to the United States who was also diagnosed with monkeypox, both men. And why I say both men is because there's a tie-in between what we're seeing with this current outbreak as well as more recent outbreaks in Nigeria. And what we see with this current outbreak is that the overwhelming majority of the cases are among men, and particularly among gay and bisexual men. And these are some of the breakdowns of the current outbreak that we received here from CDC in terms of what's taking place here in the US. I was just on a call with the European CDC this morning and have similar information for what they're seeing in terms of the distribution by age and sex in Europe. And it's exactly the same thing, where this is overwhelmingly an outbreak that's taking place among men, and particularly among men who have sex with men. Now, why I say that this outbreak is different from the monkeypox outbreaks that we've seen traditionally is because the traditional outbreaks take place in parts of Western Africa as well as Central Africa, where monkeypox is endemic. And this is Nigeria, Congo, and Cameroon, and many other places. My cousin actually lives in Nigeria, and she talks about, how there are periodic outbreaks of monkeypox that take place within the country. Now, what we're seeing here, though, is slightly different with the outbreak that we have now. And this is something that we probably should have known was going to happen. There were actually been several analyses that have been published that have shown that monkeypox, human-to-human transmission, was something that is actually taking place, and people believing that monkeypox has the potential to become an epidemic. This is from an analysis that was published in 2018. Another analysis that was published in 2020 found that, taking a look at all the monkeypox cases as well as outbreaks that they've seen all over Central and Western Africa, is that they're starting to see an increase in broader geographical ranges of this outbreak. They're seeing also a greater number of people who are becoming infected. So all of this was taking place before the current outbreak that we're seeing. The other thing that was really eye-opening as well is that there's a recent study in Science magazine that found that monkeypox has actually mutated more than 50 times between 2018 and now. So the virus has mutated. The new virus that we're seeing here is a variant, and it's acting very differently than the historical outbreaks that we've seen in Nigeria, Congo, and other parts of Central and Western Africa. And this is something that was noted just recently in a New York Times article where they're saying this is not the monkeypox that doctors thought they knew. And that's actually very true, because the way that we're seeing the clinical symptoms of monkeypox now are fairly different than what we've seen in Central as well as Western Africa for the past 50 years from when monkeypox was discovered. What we're seeing now is that we see quite a bit of oral lesions among the men who are being diagnosed, but a lot of these lesions could resemble other things, such as a common cut or some little sore in your mouth, but not necessarily something that people would think is monkeypox. So that's part of the reason why we might see some people who are being undiagnosed. For other people, it just looks like a pimple, something as simple as this here, where individuals might know that they actually have monkeypox, or a small pimple on the wrist that someone has that doesn't develop into an ulcer. So this is something that's very different than what we've seen with a lot of the pictures of monkeypox in Central and Western Africa, where you see pustules as well as lesions all over people's bodies. And these are provisional data from colleagues in Europe, where they're taking a look at the clinical manifestations of people who have monkeypox from this current outbreak compared to what we're seeing in Central and Western Africa. And there are big differences. One of the biggest differences is that this outbreak is primarily male as compared to what we see in Western and Central African outbreaks. We're seeing much fewer lesions across the body as compared to Central and Western Africa, where you see 10 or more or even 20 lesions, and sometimes even over 100 lesions that people have. And also where the lesions are taking place are different in this outbreak as compared to the outbreaks that we've seen in Central and Western Africa, where the lesions are taking place most commonly in the genitalia, most commonly in the perianal region, or even in the mouth, whereas in the outbreaks that we've seen traditionally in Africa are taking place really on the main corpus, the main part of people's bodies, as well as lesions on people's palms as well as faces. So this is a very different outbreak in the way that we're seeing the presentation of lesions and the number of lesions that people are getting. The other thing that we're seeing with this outbreak as well is that it's very closely resembles an outbreak that took place recently in Nigeria. There was a paper that was published in The Lancet looking at an outbreak of monkeypox between 2017 and 2018. And what they found with this MPox outbreak is that there were over 100 people who were part of this outbreak, 122, but it was primarily male. There's a large proportion of men who were becoming infected with MPox, which was something that people thought was really puzzling. The other thing that was interesting here too is that of those 118 cases where they had some really good demographic data, they found that 7 people died. Of the 7 who died, 4 were HIV positive. And of those 4, 3 stopped taking ART months before they became diagnosed with MPox, and 1 person was never on ART. So we're seeing these severe outcomes among people who are not virally suppressed or people who have never been on ART. And that's something that I just want you to park and think about when I get to another part of the presentation. Now, part of the reason why it's important to take a look at that outbreak that took place in Nigeria is because it took place primarily, or a large part of it, among men. And Nigeria is one of many different African countries that criminalize homosexuality among men. The state criminalizes homosexuality. And I published a paper back in 2012 looking at those African countries as well as Caribbean countries that criminalize homosexuality, and then taking a look at the rate of HIV in those countries. And what you can see really clearly is that those African countries countries that don't criminalize homosexuality have a lower prevalence of HIV compared to those that do. You see the same thing for those Caribbean countries that criminalize versus those that don't. And also the amount of criminalization, whether it's 5 years or less in jail versus 25 years or more in jail, you see greater rates of HIV as compared to those African countries and Caribbean countries that do not criminalize. And when you take a look at Nigeria, which we were just talking about, you can get a 10-year sentence just for same-sex displays of infection among men who have sex with men. So what is very likely is what we saw in that outbreak in Nigeria, where you saw more men who are becoming infected, was that many of these men may have been men who have sex with men, who could not talk about it because of the state-sanctioned homophobia that's taking place in Nigeria, and that there's elements of that outbreak and that virus is what we're seeing within the outbreak that we see today. Now, Nigeria isn't the only place where we have homophobia. We certainly have homophobia here in the US, and that's been a hallmark of the outbreak that we've seen recently. There were some scientists who were saying that we would hope that history doesn't repeat itself, that we don't see stigma leveled against people who are diagnosed with monkeypox, but unfortunately, that's not what we're seeing. Just here in DC a couple of weeks ago, there was a gay couple that was just walking, holding hands. This is actually a few blocks away from my house, who were beaten and attacked by people who said that, they have monkeypox. Neither one of these men had monkeypox, but just by virtue of being gay, the stigma associated with monkeypox was something that was incredibly problematic. And of course, I know that many of you had already seen in the news that just a couple of weeks ago that there were lab techs from many of these major companies that CDC was using, these commercial labs, to really increase diagnoses and testing for monkeypox, that there were lab techs who were actually saying that they did not want to test the blood of individuals who are coming in for monkeypox testing. Now, this is despite the fact that there are no data showing infections among healthcare workers and monkeypox. The few data that we do see infections taking place, it's among healthcare workers who are gay, who did not get monkeypox on the job. And also not to mention the fact that because of HIV, we have universal health precautions that these phlebotomists should have been taking anyway. So this is just plain homophobia and stigma, plain and simple, that really should not gotten into the way of these phlebotomists doing their jobs. We're also seeing the stigma and ignorance that's taking place, within the LGBT community. So these are just some tweets that I, just picked up yesterday, where one person is saying, I've seen so many videos showing people with monkeypox out and about, happily infecting others. We need public shaming. Scream, he's got the pox, and point at him. Shunning is another good option. We're hearing things like this that are just not helpful within an outbreak. Another person who was a gay man was saying, you already had monkeypox. I've had one vaccination, but it's too close to the event for resistance. He was going to an event, a pride event, and he's saying, why are no refunds being given? Why are we both being charged now to attend this hedonistic cesspit? Why is it being held at all? Why are these parades being open? These are exactly the things that you don't want to do. We learned from the 80s and the 90s that you do not close the venues where people who are at risk for a particular disease are congregating. You need to make sure that you have access to those individuals. You want to make sure that testing is available. You want to make sure that there's no stigma that's leveled against these people. But that's not where we're going in the US. Even here, there was this story from a week ago of a Los Angeles man. He's a young gay man who was infected with monkeypox, where all over the internet, people were deriding him and they were castigating him for going to McDonald's to get some food while he had monkeypox. Now, if any of you have seen the guidelines for monkeypox that the CDC has, it calls for isolation for 2 weeks. For some people who cannot take 2 weeks off from their job, some people who are single and don't have anyone else at home, this young man lives alone. He doesn't have anyone else who can take care of him. There was no way for him to get some food. So he got in his car and he used contactless payment to pay for food, but still people said that he should not have been out and that he was going to infect others, which was actually silly and something that wasn't possible. And also not looking at, the dire circumstances that he's in. We're also seeing stigma and ignorance that's being leveled at people who have common health and skin conditions that have nothing to do with monkeypox. So there was a woman.
Some NCAN. Dr. Greg Millet is doing. It's really good. Go ahead.
I'm sorry. So there was one woman who, just had a skin condition that had nothing to do with monkeypox that was put all over TikTok and many other areas in the internet. And this is getting so bad that there was one man with psoriasis who said, be kind to your friends with psoriasis. We don't have monkeypox. We are still people who hurt when you recoil at the sight of us. So, it's unfortunate that we're seeing the stigma now that's being leveled at people who have conditions and skin conditions that have nothing to do with monkeypox. But the stigma and ignorance is so out there that these people are being reviled on the internet. Now, one other thing that we're seeing is that the monkeypox outbreak is heavily affecting HIV positive MSM. And we're seeing this both domestically as well as globally, where we're seeing greater rates of monkeypox HIV co-infection. So much so that, the WHO estimates of co-infection for monkeypox diagnoses as far globally was 41%. There was a really nice New England Journal of Medicine article that was looking at a cohort of men who had monkeypox, and 41% of them were also HIV positive. There's another paper of monkeypox diagnoses in Spain where 40% were HIV positive. The European CDC reported that among European countries with monkeypox diagnoses, 38% are HIV positive. And then, of course, our CDC said that here in the US, 41% of people are also living with HIV. Now, one of the things that we're seeing in terms of the early data for monkeypox infections and diagnoses is that you're not really seeing a big difference in terms of the clinical manifestations for those individuals who are HIV negative versus those who are HIV positive in terms of rash, in terms of headaches, in terms of, pustules or any other differences. There's really no big differences in the clinical manifestations. The problem, though, with many of these studies is that these studies are being done with men who have sex with men who are HIV positive or virally suppressed. And part of the reason why they're not seeing any differences is that these individuals are virally suppressed. It was the same thing with data that was presented during the International AIDS Conference just a couple of weeks ago, where they were looking at monkeypox vaccine to see if there's any differences between HIV positive or HIV negative MSM. And what they basically found is that there were no differences in the first dose of getting the vaccine 7 to 14 days after the shot, where it was about 30% protective. Small differences a month out where HIV positive men, it was only 67% protective for the first shot versus 83% protective for HIV negative men. But then after 2 weeks of getting your second shot is really virtually the same between HIV positive and HIV negative MSM of about 96 to 98% protected. But here in this study, these HIV positive MSM were people who were virally suppressed. So you would expect to see better outcomes among those individuals who are virally suppressed. Unfortunately, that's not what we're seeing for individuals who don't have controlled HIV. And some of you might have seen this in the news. It's a case study of a German man who presented to his general practitioner, 40 years old, with a red spot on the tip of his nose. He was sent away. They thought that it was sunburn. Within 3 days, his nasal area started to develop necrosis. It was actually, his whole nose was literally dying, the skin on his nose. At the same time, he was diagnosed with lesions all over his body that were monkeypox through PCR testing. When they did a diagnostic workup, they found that this man also had syphilis for a long period of time. He also had advanced HIV infection. His CD4 was fairly low, and he had never been tested for sexually transmitted diseases before. So just think about that for a second. I mean, this is something that we might see more often than not in terms of what's taking place with monkeypox. This is a person, when we talk about 90, 90, 90, he's a 10, 10, 10%. Those are of those individuals who are not getting tested, those individuals who are 10% who are not being placed in care, and those individuals who are 10% who are not being placed on antiretroviral therapy. These are the people that we have to worry about in terms of this monkeypox outbreak. And in the United States, those people tend to be among communities of color who are less likely to be virally suppressed or to have undiagnosed HIV. And this case really illustrates the severity of monkeypox infection in the presence of severe immunosuppression as well as untreated HIV infection. He's not the only case. There's another case that was put forward just last week of an Italian man who really illustrates this viral storm that we're facing in terms of HIV, COVID-19, as well as monkeypox. This is an Italian man who tested negative recently for HIV. He went to a couple of parties in Spain, had sex with multiple sex partners, returned back home. Within 9 days, he had symptoms of several different types of things: headache, fatigue, sore throat, fever. All of these are symptoms that you see for HIV infection, for COVID-19, as well as for monkeypox. He tested positive soon afterwards for SARS-CoV-2. They did a workup, and then they found that he was not only positive for SARS-CoV-2, but also for a new HIV diagnosis, as well as monkeypox. So this is part of the reality that we're all living in right now, that public health officials are living in right now. We have a viral storm. We have multiple infectious diseases that are operating in tandem with one another, that are placing individuals at high risk. And they're not operating apart from one another. They're all exponentially increasing risk with each other. And we're seeing an example here of a man who's infected with all three. The other thing that we're seeing as well is that monkeypox diagnoses are differing by race and ethnicity. And just like with SARS-CoV-2, this is happening fairly rapidly within the monkeypox outbreak. These are data from CDC showing that you could see as time goes on and as the data become more complete, that we're seeing, a third of monkeypox diagnoses are among Latino MSM as well as Black MSM, and then a third among white MSM. And this is something that we write about in a quick take that I did with Georgetown University to talk about tackling monkeypox in Black and Latino communities, and you can see that online. But of course, this goes into the whole issue of first doses and what we're seeing in terms of inequities. And of course, North Carolina has been reporting some really good and important data in terms of some of these inequities that we're seeing at the state level. But unfortunately, we're seeing this as well at the national level, where you're seeing that white MSM represent 31% of monkeypox cases, but they're 45% of the monkeypox vaccines, at least the first dose of the vaccines. Whereas for Latino men as well as Black men, we're seeing that they're about 30% of cases, but only 22% of vaccines nationally for Latino men. For Black MSM, it's even worse, 33% of cases, but only 10% of the vaccines. And there's a lot of frustration that's been building for this for some time. Just like with COVID-19, when we saw that vaccines were available, that even when they were placed in Black neighborhoods, that there are people most likely who are white or privileged who are taking the vaccine slots. The same thing has been taking place in New York City, where in Harlem, this one individual is talking about the fact that this was, a vaccine site that was placed in a Black neighborhood, but all of the people in line happened to be, white men who had sex with men. And that's because the vaccines were available at times when people worked. They were not necessarily available with slots that people could get apart from being on the internet. And if you don't have internet access, and if you're not able to take off from work, you're not able to get access to the vaccine. We are seeing greater equity, though, for TPOXX access, and these are data from CDC. And TPOXX, of course, is a medication that you can take once you have monkeypox. It helps dries up the lesions that are there. It is helpful as well as pain relief and other things. Unfortunately, the data here are really limited. We're seeing that there's greater vaccine equity, that more Blacks as well as Latinos are accessing TPOXX, but it's only 300 cases. That's really not showing the breadth of cases that are actually out there. So we really don't know what TPOXX access is, but CDC even said that these data are preliminary and that they're hoping that as more data points come in, that they can get a more accurate picture of what's taking place there. The other thing that CDC has done, and this actually has been really good, they released a study last week as part of the MMWR, trying to see what some of the transmission risk is associated with monkeypox. And what they found in the MMWR is that those men who reported greater than one partner in the last 3 weeks had a 2 to 7 times risk of being diagnosed with monkeypox. They also looked among these men, and they found that one-time hookups accounted for less than 3% of total partnerships or sexual partnerships on any given day in the United States among men who have sex with men. But they accounted for 50% of monkeypox transmission. So this small group of one-time hookups on any given day account for 50% of monkeypox transmission on any given day in the US. And they said that a 40% decrease in one-time hookups would reduce monkeypox diagnoses by 20 to 31%. The good thing is that we're actually seeing that right now in the gay community. There's other data that CDC released where they found among gay and bisexual men that they're actually taking steps to protect themselves as well as their partners, where men are reducing a 48% decrease in number of sex partners, 50% decrease in one-time sexual partners, and 50% are reporting reducing sex with partners and not accessing the dating apps or going to sex venues. So, you know, in many ways, you're seeing the community actually working to try and prevent the transmission of monkeypox. And that's part of the reason why we're seeing these decreases in New York City, in San Francisco, and other places. Actually, this one person on Twitter, Nathan McDermott, a New York City resident, was saying that community activism, behavioral change, and rollout of the vaccines looks to be having a positive effect in reducing monkeypox in New York City. And that is one of the important things in public health and working with the community, which are lessons from HIV, is that sometimes, you know, the best prevention comes from the community. And we actually saw that with HIV as well. This is, you know, HIV incidence, new infections of HIV from the early 80s, where you see this huge spike in HIV infections. But then you see this big decrease all the way to 1991 in terms of new infections. And where that big decrease comes from is because people who are at risk for HIV, and primarily gay and bisexual men, actually reduced their risk behavior and also came up with other interventions to reduce HIV infection. And this was long before we had DEBIs or any other effective interventions. This was long before we had any treatment or anything else, where the community came together and responded and reduced the disease spread within the community. And that's exactly part of the same thing that we're seeing with monkeypox. The other good thing that we're seeing is that we're seeing, you know, members of the community who are taking a sting out of stigma. And we've seen that with HIV, we're seeing it with monkeypox as well. When you just think about, you know, a few years ago, back in 2014, people who were taking Truvado, particularly gay men who were taking Truvado, were called Truvado whores. These were people who were stigmatized as being too sexually active and that they shouldn't be taking Truvada, and that doctors shouldn't be giving them Truvada. And there were men who, you know, got on Twitter, men who got on Facebook, and they proudly said, you know, that I'm taking Truvada and I'm looking after my sexual health. And they took back the term Truvada whore and make it something that's empowering. We're seeing the same thing with monkeypox, where, you know, gay men like Matt Ford and many others are taking to TikTok, to Facebook and other places, and talking about, you know, what their experiences have been with monkeypox, what the clinical manifestations have been, what they felt, how their experiences were with healthcare providers, and how long it's been taking for the symptoms to clear up. This, in many ways, takes a sting out of the stigma. It makes something more relatable, it puts a human face on it, and it's exactly what we need to be doing to really fight some of the stigma here in the US. The one thing that I do want to end on is, you know, this outbreak that we're seeing, and a lot of questions that people are having in terms of whether or not this is going to extend to other communities. We're really not seeing that yet. Europe has started with this outbreak a good month and a half before us, and they're not seeing it extended to children. They're not seeing it extended to women, cisgender women, or others, and it's mainly sex between men and that's taking place. But, you know, there's still a lot of questions that people have. We know that school districts are preparing for the start of school that's going to be starting, and possible monkeypox cases. There have been a couple of cases in the US among young kids, but we're not seeing person-to-person transmission among young kids the way that we're seeing among gay men. We're also seeing a couple of cases here in Washington, D.C., where people who are homeless have been diagnosed with monkeypox. One thing, though, that we have to be careful for before we think that there's an outbreak among the homeless community is that you have to realize that LGBT community is everywhere. You have to remember that LGBT youth are more likely to be shut out of their homes compared to other youth. They're more likely to be homeless. You also find that LGBT adults are also more likely to be homeless compared to the general population. So this might be an extension of the MSM outbreak that's taking place, rather than a wide-scale outbreak that's taking place in the homeless community. So there's still a lot of questions there in terms of whether or not this may or may not extend to other communities, though the data now are showing that that's not happening. So in summary, monkeypox diagnoses are slowing, but it's not clear if this is a true decrease. We're waiting to see if that's the case. Most monkeypox diagnoses globally are in the US. We started our Vax campaign too late to prevent exponential spread of monkeypox. MPox has mutated more than 50 times, and we're seeing a different transmission route as well as symptoms compared to the traditional outbreaks that have taken place in Central and Western Africa. And as in other infectious disease outbreaks, stigma, unfortunately, has become an issue. There's a high proportion of HIV positive MSM who are diagnosed with monkeypox, but we're not seeing clinical differences between HIV positive MSM or HIV negative MSM in terms of clinical manifestations or vaccines. But the problem is that those are among HIV positive MSM who are virally suppressed, and there's clearly worse outcomes that we're seeing among individuals who are not virally suppressed. We're also seeing racial and ethnic differences nationally, and that's really a sad testament to our long history, whether it's COVID-19, whether or not it's PrEP access, whether or not it's ART access, that these racial and ethnic differences remain with any new infectious disease. The good thing, though, is that we're seeing that the MSM community is taking precautions to reduce MPox transmission, and MSM are actually undercutting and fighting the stigma. In terms of transmission to other populations, it doesn't seem like that's happening right now in the data, but I think many of us are really trying to make sure that we have good surveillance systems in play to see whether or not and to pick up if something like that may or may not happen in the future. And with that, I just want to thank you for the opportunity to present. Look forward to any questions you might have a little bit later in the seminar. Thank you.
Thank you so much, Greg. That was great information and what we all need, but a perfect segue to what Lee Stevens is going to talk about from the U.S. Department of Health and Human Services. Lee, I'll pass it right on to you.
Thank you, Valeria, and thank you, Greg. That was really extraordinary. I mean, one of the best overall presentations I've seen on monkeypox, covering it really from the beginning, the sort of genesis of what we're seeing now to where we are today. And there's so much good information there, and I'm glad that Greg was really able to capture the science here, because a large part of what we do here at Intergovernmental and External Affairs is really the public relations piece and talking to governors' offices and state and local elected officials about monkeypox, about information that they need to know, and about the ways that we can, now we're getting a little bit more data that allows us to look a little bit closer at ways that we can prevent monkeypox spread, and also some of the stigma around monkeypox that we're dealing with. One of the things that Greg brought up that was such an important piece of the presentation is where we're really failing on equity across the country. This is one of the biggest problems that we're trying to really figure out, quite frankly, how to address. And I think there will be some news this week about different ways that the administration will be looking to take on the equity challenge. But one thing most recently, and I wanted to highlight that we were recently able to have Charlotte become the first site in the country to be in a pilot program for was our special events allocation program. So Charlotte was our very first event, and that was basically 2,000 additional doses of vaccine went to the city for Pride to allow a very focused effort at outreach, because vaccinating for monkeypox is a little bit different than the kinds of vaccination outreach efforts we've done in the past, primarily because it's focused very much in a specific group of men who have sex with men. And I, as a gay man myself, I knew that this was going to be a tough summer, because monkeypox really showed up right before Pride started. It is a time when there's lots of transit around the country, people traveling to other Pride events and to cities. And so we did anticipate that spread. But one of the things that we learned in Charlotte at Charlotte Pride was that you can vaccinate a lot of people in a short period of time. They were able to immediately vaccinate 540 people over those 2 days. And they were able to collect data showing how they were able to impact on equity. And Dr. Raynard Washington, who is the health director there in Mecklenburg County, it's pretty extraordinary. in the work he's been doing, reaching out to event organizers that really are targeted to Black men. And that is something that we have not done a good job at really focusing on and figuring out ways to make sure that Black men have access to the vaccines they need. We will be making vaccines available for Atlanta Black Pride coming up shortly. So we're looking forward to learning more from that event. There will be more vaccines going to the Southern Decadence event in New Orleans and other events in the very near future. But one of the things that I really wanted to touch on here, and I want to make sure that we have plenty of time for Q&A, is there are a number of measures that can be taken for prevention. And because I'm talking to an audience here where we already understand stigma, I'm going to talk a little bit about just basic facts. And one of the things about this that's so interesting is I was growing up in Lumberton, North Carolina in the 1980s. And, you know, I was telling folks when I was in Charlotte a few weeks ago that back then, I thought I was the only gay person in North Carolina. And I thought, oh, what am I ever going to do? When am I ever going to meet another gay person? And when I went to college at UNC Charlotte, I found out that I was definitely not the only gay person in North Carolina, which was a huge relief. But it made Charlotte a special place to me. And during this era, in the early days of HIV, and what back then, I was reminded that Dr. Fauci it was HTLV3 originally. And when Dr. Fauci was announcing his retirement last week, I was thinking so much about you know, right from the very beginning, the way he fought stigma. And it wasn't very easy because he had stigma coming from two directions. He had the extreme religious right that was very, very difficult to deal with back then. But he was also getting a lot of pressure from our own community and people who in the early days, the fear of HIV was so substantial that the gay community really did attack Dr. Fauci. And one of the things that was fascinating is that he stuck to the facts and he stuck to the science throughout. And that is what survived the test of time. If you go back, and I'm sure, Greg, you have, but if you go back and look at any of Dr. Fauci's early talks about HIV in 1985, there's a really excellent one. What's so fascinating from that is that by sticking to the science, many of the things he said in 1985 are still applicable today. They are still the things we know about HIV. So what we take from this is if we take this same approach with monkeypox and we are non-emotion based in our delivery of messaging and we are fact-based, that will not stigmatize a community because everybody can get monkeypox, as we know. And so a few of the prevention techniques I want to hit right quickly. Avoid close contact with people who have symptoms of monkeypox. And this is where we have to be careful because this is not to be stigmatizing of people who have psoriasis or skin conditions, but it is particularly for men who have sex with men. Some of the pictures that Greg shared earlier really show some of the real life examples of monkeypox. So it's things that people have to be aware of, and they have to watch out for how that might possibly spread on towels or bedding and linens, especially with young people going back to college, living in congregate settings. So those things are a couple of things to think about. Also, wash your hands with soap and water or use an alcohol-based hand sanitizer. And boy, that's something we are all used to doing after the past few years. Let's see, you know, there are some facts about condoms that are kind of 50-50 what we know, and Greg, correct me if I'm wrong here, but condoms can offer some protection if the monkeypox, if the lesion is in certain areas of the body where skin-to-skin contact is happening, but condoms cannot prevent all the spread of monkeypox. They are not as effective as they would be in HIV prevention. And so we want to make sure that even when condoms are used, direct skin-to-skin contact with infectious rashes, scabs, or body fluids not covered by a condom, the transmission can occur. And just talking here, let me just hit a couple of points. I want to hit just a couple of points on messaging for gay and bisexual men, because this is really who we need to focus on at this moment in time. And I'm going to read to you straight from what some of the CDC is telling us to do. And so it's important to reach the gay and bisexual community or any disproportionately affected community with non-alarmist, fact-based messaging about monkeypox that provides people with the tools they can use to protect themselves and others. Vaccine being number one, of course. Number two are some of the harm reduction things, like making sure that you're careful with touching towels and sharing towels and skin-to-skin contact. Also, a temporary reduction in certain behaviors until you are fully vaccinated and are 2 weeks out from that second dose. That can be helpful, but we don't want to stigmatize anybody in that respect. And also, if we're trying to messaging and dissemination tactics may need to be adapted to reach the communities who need the information as we learn more about the monkeypox outbreak. So this is something that's happening in real time. Epidemiologists like Greg are the experts in this and really how to message for the future. And we really want to work with events and event organizers to make sure that they have the most up-to-date information. We want to make sure bars in Raleigh and Charlotte and other cities in North Carolina have all the most up-to-date information. And when thinking about what to do, always know that your local health department can be a trusted source of information. I realize we're bumping up against time here, but I want to stop here and turn it back to you, Valeria. And I just thank you so much for this opportunity. I'm so proud of all the progress in North Carolina and our first openly gay Health and Human Services Secretary in the state, Cody Kinsley, someone who I respect so much and so proud of. Anyway, back to you.
No, thank you so much, Lee. You and Greg have given us a wealth of information. I know that there'll be, and again, we are against time, but it's okay. Those who can stay on, please stay on. Just for a couple of minutes. I believe Greg said he has another call kind of right behind this one. There was a question that was in the chat that I saw, which was, should a person who has had monkeypox be vaccinated, or is there natural immunity? Is that something that either of you would be comfortable answering? Or maybe...
Actually, CDC is you know, if you CDC has running calls about every 2 weeks to their health partners that anybody actually can join. What's wonderful about those calls is that CDC releases a document with a running FAQ of some of the questions that they're able to answer, some of the things that they're still not sure about. One of the things that we're still not sure about, particularly with this outbreak and this variant, is the degree to which, you know, immunity lasts or doesn't last. So one of the things that we're seeing for those of us who are over the age of 50, who were vaccinated for smallpox as kids, at first people were thinking, well, if you're vaccinated for smallpox, it's very unlikely that you will be getting this monkeypox variant. But we are seeing people who are over the age of 50, who've been vaccinated for smallpox, who are getting diagnosed with this variant. So one of the other questions that people have is, you know, it begs the question of how long does that immunity last if you've been vaccinated previously and if you're vaccinated now? And that's something we just don't know yet. We're literally building the plane as we fly it. The same thing is happening in Europe and other places as well, is to try and figure out exactly how long this immunity lasts. However, I can tell you that anecdotally, you know, doctors, and I went to see my doctor last week just for a regular checkup. And this is a very sleepy practice. It's boring. You know, most of the men in this practice are gay men. And usually you don't see anybody in the waiting room. When I went there last week, the waiting room was standing room only. And when I saw my doctor, who I'm very close with, and, you know, she knows I'm an epidemiologist, she said, yeah, you know, most of the people who are there for monkeypox testing or there to get TPOXX, that this is really hitting the community hard. And she said that she's seeing quite a few people who've been vaccinated who are still coming in with monkeypox diagnosis. And why we're seeing that is that there are people who are getting vaccinated, and then just in a couple of days, they're going to Pride events or other events, and they're thinking, well, I'm vaccinated, I should be fine, without realizing that with the first dose of the vaccine, it still takes 2 weeks to get partial immunity. So you can still get diagnosed with monkeypox. You can get this infection even if you have been vaccinated, because you haven't waited long enough. And that for optimal results, that people need to get both doses of the vaccine and wait 2 weeks after their second dose before they are truly vaccinated. So we have some confusion still in the community about what getting a vaccination means, and when and how soon after a vaccination are you immune from perhaps getting monkeypox.
Thank you, Greg, for that. There's another question in the chat, and I received the monkeypox vaccine in Canada. Is this effective for the monkeypox virus here in the US? I know there was some mention of different mutations here in the US. Is that same vaccine effective?
Yeah, so the vaccine that they're offering in Canada it's the same vaccine. It's Jynneos that we have here in the US. It's exactly the same vaccine. Like you see with a lot of pharmaceutical products, it's just a different name. You have different names in different countries, but it's exactly the same formulation. So you don't have to be worried if you were vaccinated in Canada. It's exactly the same vaccine, the same dosage that we're giving here in the US.
Great. Lee, I saw that. I thought you wanted to say something too.
Oh no, I was just concurring.
Okay. Okay, fantastic. And Jody Cross, I see that you asked about women with HIV and should they also get the vaccine?
Greg, I don't know if you want to take that, but I certainly think that the first thing we would say is talk to your doctor. Every person is different, and your doctor would probably give you the best recommendation on your particular situation. Greg, I don't know if you have more to add.
No, I agree with you completely, Lee. And you know, one of the things that we're seeing, as I mentioned before, is that we're not seeing many cases right now that are among women. Where you do see that, you know, vaccines would be helpful are in Central and Western Africa, where we do see, you know, greater rates of people living with HIV in the general population, greater rates of HIV among people who are heterosexual, and where monkeypox is endemic. So at least in that setting, you know, vaccines should be available for the general population and for people specifically living with HIV. In terms of the outbreak that we have here right now, you know, speak with your doctor, but it's very likely that risk is very minimal.
Thank you for that. And then I also want to let you all know that this is just the first in the series of webinars that we're going to do on the topic. One of the other sessions will have specific populations. So we'll have someone on that call to speak specifically to women, specifically to different populations, Black and Brown, and all of those things. And I think today we just wanted to make sure you all were getting a good base for MPox and able to articulate a little bit more history about where this is, where it's going, what we see right now. And like we saw with COVID, these wonderful people on the call are giving you the information that they have, but that could change tomorrow, right? And we just try to do our very best of making sure that we are staying knowledgeable about the information that's given and direct people to the place where they can find the information. In the chat, there's some links that Greg and Lee have shared. Both of those links have information about where you can answer some of the questions that you may also have. And I'd like to thank you all for joining us today. Please continue to follow us on the NCAN site to have information about the next call, and we will be sure to share the information from today's call with the emails that you all have provided us to join the call. So thank you both for being here, and everyone else, thank you so much for taking the time out of your day to join us. And we will see you. Bye-bye. Thank you.